Welcome to the CodeCast Podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to episode 50 of the CodeCast Podcast. My name is Terry Fletcher, and today we're going to dive into compliance. So we want to look at the rules and the regulations and find out, do you even need a compliance plan within your medical practices, what they should consist of, but also really what is compliance and how does that work within the medical practices and in the healthcare field. And so the reason I want to bring this up is that, as everyone knows, as a speaker, an auditor, and educator, I find that when there are problems within a practice or audits that are not being passed, what is the outcome, or what is the consequence, I should say, for the physician or the provider that isn't doing their job, that isn't fulfilling the requirements that are needed to make sure that they are compliant. And there has to be some kind of consequence. There has to be something that they are going to have happen to them to change the behavior. And so that's what we're going to talk about and really kind of dive into this. Now, I need to do this in a couple of parts, otherwise I could be here for hours. And as much as many of you have told me, hey, we really love listening to you, it's great, and I appreciate that, 3 hours at one time, that's a lot of Terry Fletcher. So we're just going to do our regular podcast, and then you'll see me bring this up in different parts. So today we're going to look at part 1 is how we're looking at that. Also, I wanted to mention that if you hear any background noise, I did the best I could to be in a quiet place, but my satellite office is under renovations, and so I had to bring and haul all my equipment to my home office, and I live on a golf course. So you may hear some really fun background water because I live on the first tee, which is there's a water feature there. You may hear birds chirping. You may even hear a cat meowing. But luckily everybody's gone, so the house is quiet. But I just want to let you know, when you podcast, every little sound is picked up, so you have to be really careful. And I'm not in a soundproof room today, so I just want to give you a heads up on that. Hopefully you'll enjoy my off-site today, and it'll be a good podcast. I also wanted to mention last week when we talking about how to get into the medical field, and we did a little bit of coding and policy on medical marijuana. One of the things that I said, and I realized it on playback, is that we were at 12,000 downloads and listeners. We are actually at 20,500 listeners and downloads. So I kind of underestimated where we were at there. And I love my stats. I'm always looking to see, are we picking up new people? Are, my existing loyal listeners still there? And you are. And it just exploded in September and October now. So we're really excited to have you. So thank you again for coming and just being a part of the process. And I really appreciate all the feedback and everything. So before we get started, we'd like to thank Advanced MD, spotlighting telemedicine as a solution that's proven to boost patient engagement and bring in new revenue streams for your practice. AdvancedMD.com. And Healthcare Executive. Healthcare Executives Network is the fastest growing community for healthcare executives and their trusted partners. HealthcareExecutivesNetwork.org. Okay, so we are going to get into compliance, and actually I really like this topic, especially when it comes up from one of my clients from my online service, the On-Demand Coding Corner, because they ask these questions, and not only are they really thought-provoking, but I like to respond to questions not only with, I hate to say my professional opinion only, but also with some supporting documentation and citations to prove my point, to show that it's not just my opinion, it's coming from a place of knowledge, a place of research. You're nothing if you're not credible. And so making sure that you've got that background information and an authoritative site is what I like to call it, then people listen to you. So here's my question that I received, and this kind of leads into our compliance discussion. I had someone pose a question to me, and I wanted to make it a podcast. They asked if they needed to have a formal Medicaid or Medicare compliance plan when treating patients out of network for their clinics. And so when I was looking into this, it was interesting because one of the things that you need to know about Medicare or Medicaid patients, if you're expected to be paid by the state or the federal government, this includes MCOs and Medicare Advantage plans, Whether in or out of network, you're supposed to have a formal compliance plan. It's actually stated in the ACA Affordable Care Act policy and regulations. So the Affordable Care Act includes a provision which authorizes the Secretary, HHS, to mandate that healthcare providers and suppliers establish a compliance program as a condition of their enrollment in Medicare and Medicaid or the Children's Health Insurance Program, which is CHIPS, as the statute provides. So here's what it says exactly, and it's Part 7, Compliance Programs A in general. On or after the date of implementation as determined by the Secretary under subparagraph C, a provider of medical or other items or services or supplier within a particular industry sector or category shall, as a condition of enrollment in the program under this title, Title XIX or Title XXI, establish a compliance program that contains core elements established under subparagraph B with respect to that provider or supplier in industry or category. Okay, so you're probably looking at this thinking, what the heck did she just say? What this means is that anyone who is a stakeholder or what they call a sponsor are required to adopt and implement an effective compliance program, which must include measures to prevent, detect, and correct noncompliance, as well as FWA, and that means fraud, waste, and abuse. The compliance program must, at a minimum, include the following core requirements. And this is really what I'll try to focus on both of these parts. We actually might need to go into part 4 at some point, just because it's just so technical. But written policies, procedures, and standards of conduct, a compliance officer, compliance committee, and high-level oversight, effective training and education, effective lines of communication. Number 5 would be well-publicized disciplinary standards. Everyone in the practice needs to know what's going to happen to an individual that isn't compliant. An effective system of routine monitoring and identification of compliance risks, and procedures and a system for prompt response to compliance issues. So these are the minimum requirements of a compliance plan. The OIG, Office of Inspector General, they do not provide everything they're looking for in a compliance plan. Well, otherwise, how would they fund their operations without being able to find compliance lacking of some sort? Did I say that out loud? I did. But these 7 elements are functionally equivalent to what the OIG puts out in their publication, Compliance Program for Individual and Small Group Physician Practices. So with all of these rules, anybody accepting Medicare, Medicaid, Medicare managed care, you're obligated to have an implemented and effective compliance plan. So you really need to, not even just consider it, but you have to make sure that you have something in place or is working to get something in place in case it's ever questioned. And now we're starting to see private payers incorporating a requirement that providers and suppliers implement a plan in order to participate in their program. So again, to address the question that was posed to me, and with the mandates that I'm seeing that I've researched out, are participating providers required to have an effective compliance program in place? Well, the answer is depends. While most participating providers will likely fall into one or more categories, which already obligate the provider to have a program based on what payers they are participating providers with. And so we want to grasp the concept and discuss really what you need to have so that in the future, regardless of who gives you a deadline or who doesn't, that if it's ever questioned, you can say, yes, I do. I'm a physician who has or practice that has a compliance plan in the works. So let's go ahead and talk about just a couple of the items I would put in a compliance plan. And these are really some examples of what you need to have in your compliance plan. Actually, I have to tell you something funny just now. I had to stop my recording because, again, I mentioned I'm at an offsite. I'm actually podcasting out of my home today, my home office. And the mailman stopped by, my neighbor stopped by, and the UPS guy stopped by. So I was like, really? And they're all like, hey, what are you doing? We hear you in there. I was just like, I'm podcasting. And the mailman says, oh, cool. I listen to a podcast while I'm working. What do you do? So I'm laughing because it's like, I never get distracted. I'm at home and work out of my home and my satellite every once in a while. And nobody ever comes by until you podcast. So it's like, really, people? Okay, whatever. Okay, so let's go ahead and keep going. I just find things that happen like that funny because it never happens on a normal day. Okay, so let's go ahead and talk about deductibles and FAQs. Now, you may not think that's a policy that you need to have in your practice, but I thought I'd start with something simple because this is something that comes up quite a bit when I have offices that say, okay, well, we have a problem because my doctor will waive deductibles on certain population of patients. And I'm like, oh boy, no. You cannot waive a deductible. And then I'll have other practices that'll say, well, we collect everything prepaid up front and we do this. And I was like, okay, people, we need to have a conversation about deductibles and copays and what is acceptable as far as collecting that payment. And let's start with Medicare. But before we do that, we want to thank Medical Economics, Smarter Business, Better Patient Care, medicaleconomics.com, for the business of medicine, digital magazine, and health IT. So this was a question. Well, it was a situation that I had with a practice where they were telling me that they prepay or estimate, I should say, what a patient is going to have to pay on their deductible and their copay. And a lot of these are Medicare patients. And I said, well, wait a minute. So you're guesstimating how much a patient has to pay out of their pocket and then collecting it? They said, yeah, and then if it's too much, then the patient gets the money back. We'll issue them a check. I said, and how often are you doing that? And they said, oh, about 60% of the time. I was like, oh boy. So you're basically collecting money from a patient that they don't yet owe. You're thinking they might owe. Okay, we need to step that back a little bit. So when we talk about collecting a deductible, and let's talk about Medicare, how is the Medicare Part B annual deductible applied to the payment? Well, first of all, how much is it? So the deductible for 2017 and 18 is $183. And this works very similar to what private plans do as well. So for each calendar year, a certain cash deductible exists that must be met before payment will be made by the payer or Medicare, and theirs again is $183 for the year. Patient expenses are applied toward the deductible based on incurred rather than paid expenses, so the allowed amount. And these are based again on Medicare allowed amounts. Non-covered expenses do not count towards a deductible, so things that are not covered by the plan or policy. If an individual does not have Part B benefits for the entire calendar year, so Part B is when you're not in the hospital or a skilled nursing facility or a facility stay, so you're still being taken to the office, to the physician's practice from a non-facility location. So you're going there from your home, you're going there, as an outpatient. Then the insurance coverage begins after the first month of the year. The patient is still subject to the full deductible for the calendar year. Medical expenses they incurred during the year, but before they're actually entitled to Medicare, can also not be applied to the deductible. So those are patients that are changing ages to 65, or they're going from one insurance to possibly a disability coverage. And then although the date of service generally determines when expenses were incurred, the order in which expenses are applied to the deductible are based on when the bills are actually received from the payer, okay? And so make sure, again, services not subject to the deductible, such as uncovered services or bundled services, cannot be used to satisfy the deductible for that patient. Now, where do you get this from? You want to look up it's called a change request, Medicare transmittal. And there's one called 9902. It's called a CR 9902, and it talks about that. In 18, it's called, for 2018, CR 10405, and that's also an update to the Medicare deductible. So when is it acceptable to collect the deductible from the beneficiary, the patient? So when assignment is accepted, Medicare Part B recommends, since it's difficult to predict when a deductible or coinsurance amount will be applicable and overcollection is considered program abuse, do not collect these amounts until you receive the Medicare Part B payment. So the office that brought this to my attention, they're estimating, and that's incorrect. The program would consider that abusive. It says if you believe you can accurately predict the coinsurance amount and wish to collect that before the Medicare Part B payment is received, then note the amount collected for coinsurance on your claim form, but they do not recommend that you collect the deductible prior to consideration of the program because it's considered, again, abuse. And remember, deductibles apply to the year to all providers the patient has seen, not just your office. The coinsurance amount is just applicable to your services. So just an example, let's say that the patient's coming in for a colonoscopy and they are but it's a diagnostic colonoscopy, and it's typically you're charging $1,200. Well, you don't know how much Medicare is going to allow for that. I know that they allow around 237, somewhere give or take. But what can you apply to the deductible if the patient was already seen by another physician earlier in the year and some services were applied to that deductible? And I know there are websites that'll tell you if the patient has met their deductible, but some are not as updated or accurate as the patient coming in today. Now, because again, that's not isolated to your office, it's program abuse to try and collect more money than you deserve or that you're entitled to at that point. And then what about the 20%? Well, because you know the patient's going to have that procedure, it's up to you if you want to guesstimate the 20% or coinsurance. If the patient has a crossover insurance, like Medi-Medi, Medigap, Medicare Advantage, ARP, anything like that as a secondary, then you're going to be out of luck when it comes to trying to collect that because it crosses over and then there's payment coming from a secondary insurance. And so it's just interesting because you want to make sure that you are not over collecting from a patient because could show abuse and get you into trouble. And then it says, do not show any amounts collected from patients if the service is never covered by Medicare, or you believe in a particular case the service will be denied payment. Because if you do that, a portion of the provider's check may go to the beneficiary. So hopefully you can kind of see where that should be a policy in your office, how to handle deductibles and collecting them, but also understanding what Medicare and the payers say about deductibles and, the process and what you're allowed to collect and when from the patient. Another policy I would put in your compliance manual is how to use physician extenders. So this is a great example of policy because when you're trying to integrate a physician extender into your practice, it isn't a matter of one size fit all. So, how to use a physician assistant, a PA, depends on many factors for a PA. Will they be operating room assistant only, an independent practice without a physician present but working out of the same practice, independent practice with a physician in attendance, or practicing incident to an attending physician. Same thing when you're dealing with a nurse practitioner who have different options and opportunities from a legality standpoint as far as what they can do with patients, and it's different than PAs. But when you look at implementing a policy as far as using extenders, you have to understand what states allow. For example, many states allow physician extenders to have an independent clinical practice without a physician present. States do have specific rules and regulations regarding how far away the supervising physician can be and how much time can elapse before the supervising physician responds to an emergency or sees the patient for an actual new condition or a problem, and what the physician extender can do in a specific situation. But many practices use the model where it's an independent practice with a physician in attendance. That means that the physician extender sees patients and has an office within the practice's offices where an attending physician is present. And that's what they call their collaborating physician. And then the PA or nurse practitioner may have his or her own clinic and the patient and patients and is able to develop long-term patient relationships in a practice, orthopedic, primary care, etc. But many physician extenders prefer to bill under the physician's NPI number, so the National Provider Identifying Number, if they're practicing in the same office and at the same time under the Incident to rules. Now, that's a specific Medicare regulation applying to physician hands-on visits for new problems. They have to be in the practice and immediately available should there be an issue. And it's kind of like a parallel clinic situation where the PA or nurse practitioner is working independently in an exam room next to the attending physician, and then the attending physician seeing their patients. So it's kind of like a double clinic, but you have to have policies about this. So how are you going to work together? How are they going to be independent? Who's going to be in the practice? If you've got a big practice, who's on rotation to get credit for the patients that's seen that day if their doctor is not in clinic? Because so many providers now are paid based on RVUs, so relative value units, meaning how much value are their services, and then that kind of incorporates into a paycheck for them. So they're going to want to be on that rotation as a provider where services are billed out under them. But if you don't have any kind of policy on this, if you don't have a written policy, if you don't have direction, and then direction if it doesn't, if it's non-compliant, how are you going to enforce that policy? So a lot of practices that I've been involved with have been very, I don't want to say lackadaisical, but very uninformed. How about that? As far as how to use extenders in their practice and what are the actual rules when it comes to using extenders. So are we using the Medicare rules for everybody? Are we using per contract rules? So a lot of payers don't go by what Medicare says. The doctor just has to be accessible. And then there's the other payer that doesn't even recognize a mid-level provider. What do you do with that? And so having just even that, tackling that big concept as far as using mid-levels is going to change the way you practice, and it's going to bottom line your reimbursement. And so you can see I've just brought up 2 issues that need to be addressed within a compliance manual. And we've already opened up the billing office. We've opened up the clinical side, and we haven't even scratched the surface on the front desk, on the physicians, on documentation, on who gets audited. I mean, it is such an undertaking to make sure that you're not only are you compliant, but that you have compliance plans in the work as far as checks and balances. And that's really what that is. I've given you 2 issues from 2 separate departments, and those checks and balances have to be done because the penalties for non-compliance with payers can monetarily just absolutely handcuff your office, and you don't want that to happen. And so look into some of the webinars that we provide for that. I have it on my website at terryfletcher.net, and we really help you put in a compliance plan in place, how to start one, how to get one in the works, and really how to be proactive in your compliance plan. So what I'll do probably as we continue in this process talking about compliance and how to get started in creating a compliance plan is we're going to break it down first by department and then by actual category and then by employee that'll be responsible. And then again, we want you to be educated on it and have actual tangible documents to be able to create your own. And you'll be able to find that from a webinar series. So this is to get your feet wet in it, to really talk to you about it so you understand the concept. And then we recommend that you really take an educational piece to do that. So really kind of keep a lookout for that. Next week, I will get into more compliance issues in part 2 and looking at some of the things that the physicians need to do, which actually comes from accurate coding and documentation. So we know that your staff codes, and that's fine if you're one of the staff that are doing any of the coding for your physicians. The billers sometimes are also coders. But what is important to know the concept here is regardless of who's coding in your office to submit a claim to a payer, the responsibility for coding ultimately lies with the physician and the practice, not the coder. Yes, they're responsible as a job function, but responsibility as far as compliance, that really falls back on the physician. It's your name on the claim. And so as I'm auditing, and I'm really undertaking a lot of auditing lately, a lot of E&M services, some surgical and some procedural services. But one thing I noticed, and this is something else that you want to incorporate into your compliance model, and this is one of our coding questions today. So something came up, it says, Terry, we're talking about HPI and the chronological description of the development of the patient's present illness when they present to the physician. And I'm finding that the doctors usually are doing a 3-element brief HPI, history of present illness, or they're trying to say, what do I need to do to get to an extended? Which is a dangerous question because you don't want to tell them to do this so that they can upcode. But if they're providing the service, you want to say, okay, so here is what you're doing based on what I'm reviewing. And that's actually a more extended history of present illness or HPI. And so what things that you want to take a look at? Part of an HPI is that there are 7 or 8 HPI elements that Medicare and Medicaid payers look for, again, that chronological description of the development of that patient's present illness. And we call it the history of present illness or injury. It's location, quality, severity, duration, timing, context, any modifying factors, and then associated sign or symptoms. Now, one caveat you may not know, and when I bring this up to people, they're like, no, oh my gosh, you're right. The CPT book, the AMA guidelines, does not include duration in its list of HPI elements, which to me is weird, because how long has the patient had the condition? So some private payers might only use the other 7 elements, but Medicare does use duration, so we really try to follow their rules as well. But if you're unsure of a payer's policy on HPI elements or the list, make sure you're calling the representative to check. But once you've got a handle on what the HPI is and which element list you're going to use, now you're ready to check the encounter if you're the auditor to determine what the provider performed. So a scenario here, a Medicare patient reports to the orthopedist with a chief complaint of shoulder pain, which would be location. The patient reports that the pain has gone on for about 4 months. That's duration. Now I have 2. So the provider reviewed 2 elements. So this is an example of a brief HPI. And when you're talking about brief, you're looking at lower levels of service. Level 1, new patient office visit. Level 2, established patient office visit. But to be able to get to an extended HPI, that means the care might need a detailed or comprehensive history, which is part of that history of present illness. And that's for a level 3 or 4 or 5 new patient visit, a level 4 or 5 established patient visit. But an extended HPI does not guarantee a higher level E&M service. It only makes reporting these E&M codes possible. So the provider must still satisfy other encounter requirements. So the review of systems, do not forget the past family social history level, the physical exam level, and obviously the medical decision-making level to really look at what your CPT or E&M code is going to be. But let's go back to that shoulder pain example for the orthopedist. So Medicare patient reports to your office complaining of shoulder pain, and the provider asks, where is the pain centered? That's your location. How long have you had the pain? That's the duration. How would you describe the pain? That's quality. How bad is the pain? On a scale of 1 to 10, that's severity. Now I've got 4 elements. If the pain is worse in the evening or when you've been moving or walking a lot, that's timing. If the patient has had any pain in another area of their body, or is it radiating down their arm, that's associated sign or symptoms. And have they taken any pain relievers to deal with the pain? Modifying factors, but make sure you list exactly which pain reliever. So I took Tylenol and it resolved for this or did not help. That's where you get into that extended HPI. So you're counting as far as making sure the physician is completing that entire concept of diving into that problem for the patient. And so you can find from the first sign or symptom until what happens to the next encounter. And that's how you really look at that extended HPI. I bet your physicians are providing that service anyway. They're just not documenting what they're doing. And that's where they tend to really discount themselves on being able to capture services. You know, when we go over HPI, and when I train for E&M services, first thing I say to them, and they're like, well, I'm doing that. I said, okay, well, you might want to tell somebody in your documentation because it's auditing at this level, even though you're actually providing this level of service. And so again, when we get back to compliance and the training, education and training is huge on compliance because you can't expect someone to do something well if you don't tell them how to do it first and what the expectation is. And so I see that all the time. Very poorly trained staff members, poorly trained physicians. And for the physicians that are on the call, and I know there's many of you, you contact me daily. Yes, as a physician, you still need to be trained on how to document. You know, the proposal for Medicare that's coming up next year, all it's going to do is change your payment. It's not going to change how you document, even though they're saying, well, you technically only have to document possibly for a level 2 to a level 5, and you're going to get the same payment. Well, compliance and med legal isn't saying that. That's just a payment comment. And so you still have to have compliance in your documentation. And so really just keep that in mind as we move forward in this compliance discussion, because training is going to be a big key. Again, your expectation can only be as good as how you train and what you tell people you expect of them. And so we just want to make sure we're clear on that. And then today, our final sponsor is Keck Medicine of USC. Over 500 nationally renowned physicians at a leading academic medical center, keeping you healthy, on track, and doing things you love. KeckMedicine.org, ranked in the top 50 hospitals in the country by U.S. News and World Report, and is number 1 in Southern California in cancer care. Also, for those of you that have inquired about being a sponsor for our podcast, thank you so much for your continued support. We have some premium spots available coming up this later part of the year, and then also beginning of 2019. Email me directly at terryfletchercpc@aol.com, and I'm more than happy to get you on the schedule. We really, truly appreciate all of our sponsors and are proud partners of the CodeCast Podcast. Part of our Giving Back and Making a Difference campaign, check out 4oceans.com. For every bracelet purchased, this funds the removal of 1 pound of trash from the ocean. Again, 4ocean.com. So before I close today, exciting news, we are now on Spotify. So you can find us on almost every platform now: Spotify, iTunes, Stitcher Radio, TuneIn, YouTube, you name it, we're there. Please leave us a rating, leave us a kind comment. As far as a review, we'd really appreciate that. And again, we appreciate our over 20,000 listeners that we have now at our 50th episode. So everyone, make it a great day, and I'll talk to you next week. Thanks again for tuning in.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.